Hello everyone, my name's Claire Smith. I'm the Chief Operating Officer and Deputy Chief Exec, and I'm here on behalf of Phil, chairing this report out on behalf of Phil, who's on his last day of annual leave. We've got quite a bit to get to today. I think we've got, if I'm still right in thinking, we've got 3 presentations today, so we will need to stick to time. So I'll do my best not to be blunt, but if I start looking agitated, it's because you're getting near time. So I will say if we go a minute over the sort of the time, because I'd like everybody to have an opportunity to share. So on that note, I'm going to hand over to Amy, I think, to take us through the urgent care 60-day report out, please.
Thank you, Claire. My name's Amy Colson. I'm one of the Senior Sisters in Urgent Care at the LGI. I've been asked to come and do the 60-day report out for our patient flow and RAU trial that we started in November. Could I have the next slide, please? Thank you. So there's a project form from November. We started the project initially due to high patient demand and long waits in our RAU area in A&E, often causing frustration for patients and staff and a difficult working environment. So we wanted to see how we could improve the area, and we decided to trial joint nurse and clinician assessments as our idea. Next slide, please. As you can see from the table, we had a positive effect during the trial, and we reduced the patient's time in ED. Unfortunately, there were some difficulties during the process. So as a CSU, we've decided to pause the process. So that's why there's no data in the 60-day column. Obviously, we would have collected that data. However, we've paused it. If we could have the next slide, please. So the function of our pause was to do a PDSA cycle. We felt that staff feedback was really important to us, and obviously there's a lot of staff groups that work together within ED, so we've gone for feedback to the consultants, the junior doctors, the ACPs, the nursing team. Anyone that's involved really has been sent this feedback form to complete. We've had a good amount of responses so far. The common themes were the nursing staff being concerned about being de-skilled. They've got a lot of extended triage skills that we really want to keep up, so it's about looking at how we can keep those skills up whilst also increasing the flow through RAU. We thought the SDM, so senior decision maker involvement, was really important to be early on in the patient journey, and that's come back through the feedback as well. That was something that we already knew, but obviously our senior decision makers are limited. So where we utilise them in the department, we have to be clever with it, really. But that's come back through the feedback that people are really engaged with that idea. It also showed us that there was a high mental load on the junior clinicians who may not be used to it. They normally have a little bit more time to think, to see patients, to formulate plans. Whereas in this model, they were sort of being expected to make those decisions quicker and the turnaround times be shorter. So that was quite difficult for a lot of them, I think, to get on board with, compared to the more senior doctors who are used to having maybe a quicker turnaround time. And also the main issue that we had was the pure demand was outstripping the capacity that we had to run the trial on a lot of occasions. So, you know, with all good intentions, we'd do the trial, and then, you know, we'd have 20 people book into RAU in an hour, and it's how do you manage that demand with a new process? And it's very easy to revert back to old process. So during the next 30 days, we will be collating this feedback to try and formulate a new process, and then propose that new process. And then we're hoping, if we can formulate it in time, that the new process will be implemented in the week commencing the 4th of March. Obviously that will need reviewing frequently, and obviously we'll be taking on board any feedback from staff before then and obviously during that time.
Thank you. We'll take questions at the end, but I'm just going to observe just for a moment. We've got a terrible tendency in the NHS to think of a process, laminate it, put it on the wall and say that's what we're doing. And part of the beauty of the Leeds Improvement Method and part of the benefit of the Leeds Improvement Method is that safe PDSA process that we can go through to be able to determine whether or not it's working and whether it's not. So I see this as a success. Amy, not a failure, and I hope the team don't see it in that way, because it's those check and balances that are so incredibly important in terms of sustainability of process moving forward. So thank you for that, and thanks for sharing that. We'll take questions at the end.
Thank you.
Okay, moving on then to, I think we've got Alice on the call. So this is improving care of ED patients sustaining fracture. I could put my teeth in. Fractured hips. That could have come out very badly. Right, over to you, Alice.
Hi everyone. Yes, I'm Alice. I'm one of the ST6 registrars in A&E at the minute, and I started to look at patients who came into A&E with a fractured hip, or what we call it, fractured NOFs, which is neck of femur. Next slide, please. So I noticed through a few shifts that patients with fractured NOFs were waiting in A&E for absolutely ages, and we already had a pathway and it was clearly not working. So this is just an example of some timed observations that I looked at. So a patient came in at 10:30, an x-ray was booked at 11, the x-ray was done at 20 to midnight, seen by an A&E doctor at 4 o'clock, and then TCI means to come in to book in a bed at 4:30, and then eventually leaves A&E at 2 o'clock the next day or later on that day. So it took a time to book a bed of nearly 6 hours, and a total time in A&E of 15.5 hours, and this wasn't the only one by far. So I started to look and think, why was this happening? And actually, if I could improve this bit, then it would fit very nicely with the 7 C's, reducing finance, potentially reducing overall length of stay, quality improvement, and hopefully give a bit of feedback back to the A&E nurses to say that actually we can change something and improve staff morale. Next slide, please. So actually, through the timed observations and asking some A&E nurses on the YAS triage desk what was actually happening, it seemed to be that the x-ray was done, and then it solely relied on the same A&E nurse to review the x-ray. Now, A&E nurses, they're very good at picking up the x-rays, but they're not trained to review x-rays. Sometimes they have to go to a doctor to have a look at the x-ray. So as well as that, they've got a ambulance corridor sort of filling up with patients, trying to get them off ambulances. So I felt like it was a really unrealistic expectation of the A&E nurses to be able to do this. And one night we had 6 patients with fractured hips, and it was just so unrealistic, this model. So I, with liaison with a few A&E sisters and the lead for radiographers, I got the radiographers to now ring through when they see a confirmed hip fracture. Really simple. They just give a phone call to the PFC phone, which is patient flow coordinator. Then that would highlight the patient, put them on the NOF pathway, quickly book a bed, and hopefully reduce the overall time in A&E as well. Next slide, please. So actually, I've tried to collect some data. This is just a sample of patients. It's not all the patients. So it was 6 weeks pre-intervention and 6 weeks post-intervention, 38 patients included. And actually, you can see a downward trend. The purple arrow shows where the intervention happened just before Christmas. And actually, if you look at the time to book a bed, so pre-intervention, the median time was actually 238 minutes. Post-intervention, the median was 139 minutes. So we've actually improved the time to book a bed by 1 hour and 40, just under. Next slide, please. So same patients again. I looked at the overall time in A&E for these patients. So pre-intervention, the median time was 879 minutes, and post-intervention it was 498 minutes. And actually, so that reduced the overall time by 6 hours 21 minutes. And then after speaking to some people in the Leeds improvement method course for this presentation, they said actually there's a lot of work trying to reduce the time to surgery. So I tried to collect that data. Next slide, please. So this is the time to surgery for these same patients. So pre-intervention, it was 67.5 hours. Post-intervention, it was 43 hours. So a reduction in time, median timed by 24 hours. Next slide, please. I tried to create some balance measures just to make sure that if we were getting patients on the pathway and out of A&E as soon as possible, we weren't having a negative impact elsewhere. So just to make sure that they were getting fascia iliaca blocks done for pain management. And actually we've improved that. And then a process measure, I can't at the minute for certain say that every patient has been phoned through, but what I can do is say if the patient is on the NOF pathway and if it's working. So that has improved as well, although there's still some more work to be done. Next slide, please. So actually, it was just something really simple that I thought, gosh, this just isn't working. And after just a few conversations with people, it was really taken up really well. And so the enthusiasm by the A&E nurses and the radiographers has made a real difference. And I don't think I would have been able to do it without people's input. Next slide, please. So yeah, in the future, I think I'd start to collect data from the beginning, because then I wouldn't be keeping going back and forth and trying to collect more and more data as I find out more about different bits and bobs. But this just shows that this piece of work is just a tiny intervention that can make a really big difference. And sometimes it takes another perspective within the same team, but maybe as a doctor to say to a nurse that I can't believe that's in your job description, it's unrealistic. And then so in the future, I've already fed back this data to the nurses and the radiographers, and hopefully I'm going to present at the clinical governance meeting this month about it. I've already spoke to the lead clinician in A&E to improve the NOF pathway, and we should hopefully just keep talking about it and more education to increase the percentage of patients on the pathway. So yeah, thank you very much for listening.
Thanks very much, Alice. I'm going to go straight on to Melanie, but I'm going to come back to you, Alice, because there's a lot in there that I wouldn't mind. Well, there's a lot of conversations happening about NOF, so this is very, very timely. So thank you. Yeah. So let's go straight to Melanie then, please.
Morning, everyone. I'm going to share my own slides. Hopefully this works. Can everyone see that okay?
We can.
Lovely. So welcome to my report out about the Weights Matters project. The Weights Matters project is facilitated by the Weights Matters group, who are a QI group that are closely linked to the recently launched nutrition mission. The group was developed following a serious incident in the trust. After the investigation, it became clear that there was a trust-wide issue with obtaining accurate weights for patients. Weighing is often not seen as a high priority task, and for some staff groups there's a lack of understanding around risks and harms that can happen as a result of inaccurate weighing. And since a specific question relating to this was introduced to the ward metrics in November 21, the trust has only achieved green metrics for 1 month on 3 separate occasions. So using LIM methodology and tools, we wanted a way to help wards and areas identify barriers to accurate weighing and support the team to implement improvement ideas. We used a driver diagram as a tool to break down our plans based on a clear aim, which was to achieve green metrics trust-wide consistently for 4 months. We used a PDSA approach to structure our project. Through this, we identified potential wards in need of support via the trust metrics and contacted key stakeholders. We selected to work with L10, a ward that cares for patients with major trauma injuries. We developed an in-reach document designed to assess staff knowledge, equipment availability and suitability of that equipment. This tool can also be used to identify any defects in processes, such as reporting of faulty equipment or adding weights to e-meds. We also did process flow charting that helped us identify additional types of waste in the weighing process, such as motion, over-processing and skills waste. After gathering this information, we decided on a test of change to implement using another Leeds improvement method tool in the form of a weights huddle board. So this was to be displayed at the nurses station where the MDT huddle took place, so it could be reviewed and discussed with the team to encourage an MDT approach. This board included visual controls using colour coding to identify patients who had not been accurately weighed. We also developed an audit tool to monitor an outcome measure to assess the impact of the implementation. We also reviewed the reasons for unable to assess and patients' mobility status, and this helped us identify if there was a particular patient group that were not getting weighed, and if there were any common themes for not assessing weight in that area, and this would provide focus for potential improvement ideas. To keep the team engaged, we regularly visited L10 and completed Gemba-style walks to gain opinions and feedback from the wider team. I'm not sure how well you can see this, but this is an example of the huddle board. It's obviously on a larger scale in reality, and it identifies if the patient needs weighing, when the reassessment is due, what equipment is needed, and it's colour-coded red for those who need weighing and green for those who have an accurate up-to-date weight. So it's just a really simple intervention that can be adapted easily for other areas. We also did some work around incorporating coordination of weighing into leader standard work. So we encouraged the nurses in charge of the shifts to ensure that the huddle board was completed, not necessarily by them, and they allocated a daily weights champion to review this board and facilitate weighing for that day. Additionally, from the data collection and feedback from the team, we produced a new test of change to make further improvements. We identified gaps in knowledge and developed an education package, which we have now started to deliver to the ward. We also identified that the current equipment was not appropriate for major trauma patients, so we facilitated the loan of a portable bed scale, which you can see here in the picture. There's just little pads under the wheels, and these were a huge success, and the data reflected to show an improvement during this period that had this equipment loaned. Since the beginning of the work began last year, we've had many ups and downs and factors that have affected the data, which we have mapped on the run chart displayed. As shown, things such as broken equipment, management changes and high acuity of patients have all had an impact on the team's ability to weigh the patients. Despite these challenges, the hard work and perseverance of the team has resulted in two-step improvements that we can see here on the run chart. We've also been able to attend the ward to celebrate the success and give out some certificates and treat as shown in these pictures. Unfortunately, in recent weeks, we have seen significant events affect the data again, but we are continuing to support the team and have more education sessions planned in. Through our work with L10, we've identified trust-wide issues and implemented changes to the wider trust to help improve practice around accurate weighing. Additionally, we've gained good understanding of barriers in clinical practice and have raised awareness about the risks of inaccurate weighing. We have also implemented changes to the DATEX system to help us identify harm and measure risk to patients. The knowledge and education gaps that we identified have allowed us to develop an education package that can also be shared trust-wide. We identified that poor documentation practices affecting accurate weighing, and we have implemented changes to PPM to standardise and improve this. And we're also developing an intervention bundle where we can share improvement interventions with areas in need of support. In terms of what I would do differently, the involvement of more junior staff from the start of the project is key. Information about the improvement work can take time to disseminate to the junior members of the team, but the people on the ground are integral to help progress the improvement work and often give you the best ideas. Visibility is key, and as I say in LIM, go see, ask why and show respect. Emails back and forth just aren't effective, so going to see the team, observing them in practice and helping them overcome the barriers is essential as it builds relationships. So when supporting new areas, I would like to do more face-to-face support. Celebrating with the team helps them feel valued and show them the hard work is being recognised. So this is something I want to continue to incorporate into future projects. Going forward, I would like to utilise direct observation tools to provide evidence of waste and dispel mental valleys that we've found around improved weighing, creating increased workload for MDT members. I'd also like to develop ways to collect additional LIM metrics around morale of the team and how they feel about the improvement work. So the next steps are now to take these tools and learning points and spread the work further throughout the trust to achieve our aim of green metrics consistently for 4 months. And that is it. Thank you for listening. I do have the QR code for our weight. It's not a survey. If anyone would like to do that, and if that's allowed, I can pop that in the chat. Thank you. That's it.
Thank you so much, Melanie. Right, that were 3 brilliant presentations, but we've got 8 minutes left, which is absolutely superb as well, because so we've got time for questions. I have got questions, but I'm going to see if there's any hands up first before I launch. Okay, I have. Excuse me. It's come up as Dolph M. So apologies.
Hi, I'm a patient partner.
Hello there. Hi.
Dolph Morgendorf. Hello. Sorry,
there.
it comes up like that. Sure. Yeah, I just wanted to congratulate the team who have been working on the greatly improved timing of patients coming in and getting their hip dealt with. As it happens, an old friend of ours in the 90s had exactly that experience recently, and we were all absolutely delighted at the speed at which things happened and how efficient and effective they were. So I just wanted to say thank you, congratulations.
Thank you for that. Jenny.
3 great presentations, and thank you for giving us the time for questions as well. Really brilliant. So I think for all of you, well, Amy, great that you're using the improvement method to manage the pause. And I agree with Claire, it's brilliant that we're safely testing something and keep finessing it. Do you think there's anything in the feedback that you've had so far that's going to sort of hinder you achieving that 4th of March date? I just wondered whether there was anything in the feedback where you're thinking, gosh, we don't know what we're going to do with that.
Yeah, I think there's a lot of small and large ideas in that feedback. There's a lot of everybody loves it to be asked their opinions, don't they? So there's a lot of ideas in there, some smaller, some bigger, but there's loads of things that we can look at in REU in general, and it might not just be that assessment process, but it might sort of be more of the team as well. There is some wider work going on. I've just been speaking to one of our consultants, some wider work going on about streaming people away from ED and using ambulatory assessment areas and things like that. So I think that's definitely been mentioned as well. But obviously, if we can reduce the demand, we can finesse our internal processes a little bit better, because we're not, that's, like I said, the main issue has been the high patient numbers, really.
Well, as I said to Jane, let's get the R back into our AU. I can see her on the card.
I knew you were going to pick up on that. I knew.
Couldn't help it, Jane. I'm sorry.
It was inevitable, Jane.
Once a coup, always a coup. Right, James.
Hi, I'm James Goodyear, Director of Strategy. Fantastic presentations, guys. Alice, just really impressive results, and we know that fractured NOF is such a serious condition for patients, so these improvements will undoubtedly improve their experience and dare I say that their outcomes. And what I was really struck by was the way that you're demonstrating the Leeds Way values in your application of LIM, particularly accountability. You've seen a really important issue, and you've done something about it, working with colleagues and collaborating with them and looking at how the process can be improved, which is absolutely fabulous. Melanie, what a tour de force of the application of QI to an issue. I felt like that was almost like a mini seminar on the way that different tools in QI can be used to get underneath an issue, to test a change, and to look at the impact of that. Fantastic. And Amy, as others have already said, it's really good to pause and reflect. That's a core part of the PDSA cycle. And it sounds as though, by the way that you're engaging colleagues in that, you're very much maintaining momentum to the achievement of the overarching goal of your improvement work. So really good and well done.
Thank you. Alice, I mean, it really could not be more timely, actually, the work that you're doing here. We saw over Christmas time that some of our patients were waiting an inordinate amount of time for access to surgery. And of course, that 15 hours that you're talking about, it's somebody that's probably had a fall, is probably very vulnerable in a very crowded ED, as Amy has already described in her first presentation. You know, it's not great, and the level of impact in terms of a person's outcome from an extended wait in order to be able to get their surgery is significant. So in a very unsophisticated and very Leeds improvement method way, I've taken a screenshot of your slides as we were going along, and I'm going to send them to Beth Barron, who is supporting us on a review of the neck oedema pathway. Because I think we're going to try for an RPIW in the non too distant future, and it would be brilliant to have your input into that, Alice. It really would. So I'll share that information, and I think I would say have no doubt at all. And well done for linking the 7 commitments to your presentation as well. But I have no doubt at all that the work that you've been describing has a direct impact on length of stay, because it does. Outcomes, experience, and length of stay. Melanie, this might be a really difficult question, and I'm sorry if it is, but what I was reflecting on, because that was a really great presentation, but what I was thinking of is I understand a little bit why people struggle to make it part of their daily practice, and why because it does feel, as you've already communicated, feel like another thing to do. And what I'm wondering is, because there is such great initiatives that are happening through this work, and James is right, it's a brilliant example of QI work, is how do we make it more, and I say this might be impossible to answer, but how do we make it more integrated in the way that we work, so that we don't layer up different boards and different things each time? It becomes part of practice, and that's the nut I'm not sure that we've cracked yet organisationally. And I wondered if you had any views on that from your own experience.
Yeah, no, I completely agree. But part of the process mapping and identifying the waste and things is when the tasks are already being done, is trying to incorporate weighing into that task. So when they're having the PT session and they're moving the patient anyway, try and do the weight at the same time. When you're moving that patient to wash the patient, do the weight at the same time. So not making it an extra task, making it part of the process. And it's a bit about a culture change as well. And that's what we've found with the in-reaches we've been doing and getting the feedback. And that's why we've developed the education package to kind of highlight the risks and make it more at the top of people's agenda, and try to give them examples of how they can make it part of a process rather than an extra task.
Thing.
So yeah, exactly. So making it part of other processes is what we're trying to push the message forward, and just change that culture a little bit and get it a little bit higher on people's list of priorities. But yeah, I know exactly what you mean, and that is some of the things we've found as well.
Well, thank you. Well, we're bang on 1 o'clock, so I'm going to stop us there, but really enjoyed that. Thanks so much for sharing those 3 presentations, and I think it's recorded as this, and we'll make sure it's referenced in our week, so that other people can, because I think there's a lot of learning that other people could take across the organisation from what we've seen today. So massive thank you to you all, and I know Phil will catch up with this as well, so he won't miss out on it. Okay, well, thanks ever so much, everyone, and take care. Enjoy the rest of your Friday. Bye.